So we're at a Hesch seminar, and the subject of the seminar is the lumbopelvic hip complex. But I wanted to give a demonstration on reflex phenomenon causing hypermobility. Sadie volunteered, and she tells us that she has ankle laxity. Now, in advance, I don't know if Sadie has true damage to her anterior talofibular ligaments, and that is a kind of laxity that would require long-term splinting, and lots of rehab, lots of exercise, balance, proprioceptive exercises, endurance, and strengthening. Or is there inhibition through is there inhibition of muscle tone affecting ligamentous tone, or muscle tone affecting stability of the ankle through the tendons, because that also contributes to stability. It's not just ligaments. So I'm going to do a drawer test. So I'm stabilizing tibia, and I'm drawing the calcaneus forward, and I can feel a clunk. And I think the camera angle can see that easily, that there is an excursion there. Now, would you come over and film the other side, please? So I'm going to stabilize tibia, and I grab calcaneus, and I am doing the very same test, and I see the tiniest excursion. I doubt that the camera will be able to see it. How does it feel when I compare your right to your left?
Stronger on this side, more loose on that side.
Okay, so you feel stronger on the left ankle and looser on the right ankle. So keep filming. Let's look at your strength. Can you dorsiflex this foot? Show me how strong you are. 1, 2, 3, give me everything you got. Very strong, excellent. Now go into eversion. Good, give me everything you got. 1, 2, 3, go. So I can break it easily. Evert this one, show me how strong you are, give me everything you got. Okay? Now, I would call the right ankle hypermobile, but not unstable. It gives me an optimism that maybe I can do reflex therapy, and I can stress your lateral ankle, stress that anterior talofibular ligament on the left side, threaten it, and by way of the type 3 and maybe even the type 4 receptors, they're going to inhibit muscle function on this ankle. They're going to tell me, stop doing whatever you're doing, you're hurting me. We're reciprocal creatures with gait, we're reciprocal, so we have a lot of wiring for that. It's going to inhibit muscle function on this side transiently, but increase muscle function on the opposite side. It wants you to run away with the strong leg, lead with the strong leg when you run away from the injury, whatever's causing your injury. So we're going to stress this right now, and I'm going to grab it, and I'm drawing it with a moderate amount of force. More force than I would use with testing it. And I'm going to twist it into inversion and anterior drawer, and then I'm going to oscillate it 30 times. And this is one of those techniques where it works or it doesn't work. There's no subtle in between. Okay? So in a couple of seconds, I'm going to be excited by the results, or I'm going to be disappointed. Either way. Okay? So let's come back to this other side. Now, evert that foot. On the count of 3, give me everything you got. 1, 2, 3, go. I cannot break it. Good. Relax. Now I'm testing it. I'm trying to draw it forward. I'm using a lot of force. I'm using more force than I used initially. Can you tell? Maybe?
Maybe.
Maybe? Am I putting a lot of force?
Moderate.
Moderate. Okay. I'm not getting that excursion. Okay? Can we have you walk? How would you test that how would you test that ankle?
Oh, probably, actually a lot of dorsiflexion will actually irritate a lot, or a lot of plantar flexion will too, but
Okay, does that still do it?
not as much, no?
Okay, would you tell walking?
Probably not. I could probably test a little bit there. Yeah, it's usually not, I mean, kind of pinchy and stuff like that, so not as much.
Okay, so it's less pinchy when you bend down.
Mm-hmm.
Very good. No other paces we could put you through?
Probably not.
Okay, so anyway, thank you. This was a demonstration, keep filming. This was a demonstration that sometimes joint laxity, joint hypermobility is actually driven by neural inhibition. And the muscle tone is reduced, and muscles and tendons contribute to stability in a joint. And maybe it's simply inhibition of those structures. But actually, there's a lot of connection between muscle and ligament also. No such thing as, pure ligament that goes from bone to bone in a majority of our body. Oftentimes there's muscle nearby with fascial and aponeurosis connecting muscle to ligament, connecting tendon to ligament, especially in the hand. You look at that dorsal hood, and it's just fascinating. Surely that adds stability. So there's a couple of different models, a couple of different ways of looking at it, and one is of a chronic inhibition post-injury, and we sort of erase the hard drive. We reboot the computer by stressing the ligaments in the opposite side of the body for temporary inhibition, and then reflex facilitation to the injured muscles. So there's one model. There's almost nothing on it in the literature. I wish there was more research on it, but go out and experiment with it and spread the word. Thank you.